Hello, my name is Eugene McNally. I'm from Oxford in the United Kingdom. In this presentation, I'm going to be talking about some of the conditions that can cause pain on the dorsal-radial aspect of the wrist. I'll be focusing in particular on the first three dorsal compartments and on the sensory branch of the radial nerve. I'm sure the anatomy is very familiar to you. The three compartments comprise 5 tendons, 2 pairs and 1 solitary tendon. The radial nerve plays some role in causing symptoms in this area, so we'll talk a little bit about that. And of course the important overlying extensor retinaculum. These tendons, like any other, are prone to the usual diseases of tenosynovitis, tendinopathy, partial and complete tears. However, because of their unique anatomical relationships, where the second extensor compartment passes beneath the first and the third crosses over the second, and in particular because of the presence of the extensor retinaculum, the area is prone to a number of unique conditions, and it is these that I plan to discuss in this presentation. The most important of these is de Quervain's disease, or Sclerosing Tenosynovitis. There are some well-known sporting and occupational associations, but a not infrequent clinical presentation is in lactating women, and this is due to holding the baby between thumb and index finger whilst the baby is being fed. Clinically, it's not a challenging diagnosis with the Eickhoff and Finkelstein's tests. This is how you do a Finkelstein's test, and this is quite useful to know for ultrasonologists. You make a fist with the thumb tucked into the fingers and ulnar deviate, and pain occurs over the first dorsal compartment. There's a fairly typical set of imaging findings. Commonly there is fluid within the tendon sheath, and signal changes with increased Doppler activity and hypervascularization can occur within the tendon. However, most important and particularly to emphasize is the thickening of the overlying extensor retinaculum. In long-standing cases, and because this is a polyenthesis, bone signal changes can occur, including bony erosion, which can be detected on MRI or on X-rays. As is often the case, axial T1 weighted images are very good at showing the internal signal changes, indicating that there is a tendinopathy associated with the tenosynovitis. But one of the points I particularly want to emphasize is that many cases of de Quervain's disease show very few signs related to the tendon sheath and tendon, and often the only abnormality is the thickening of the extensor retinaculum. And this can be very difficult to see on MRI, but much easier to find with ultrasound. The thickening can be mild or marked. It can be avascular or occasionally associated with a very intense Doppler activity. Another advantage of using ultrasound is you can go directly from diagnosis to treatment. Here is an example of a simple intrasheath injection of corticosteroid and local anesthetic. However, if the extensor retinaculum is particularly thickened, I also include a percutaneous division using a 16-gauge needle in the treatment. And in the second video, we can see in long axis the passage of the needle moving several times across the sheath, followed by deposition of a little corticosteroid in the treatment bed. A number of variants are described, and some have important clinical implications. Probably the most important of these is to detect whether there's a septum separating the two tendons within the sheath, as in this case, and these can be quite common. The important clinical aspect is that if the sheath is to be injected in the presence of a septum, there is a possibility that only one of the tendons would be treated, resulting in treatment failure. Another common variant is when multiple slips are present, and it is important not to misdiagnose this as tendon delamination or tear. Usually the normal internal echo or MRI structure within the tendon slips is a good clue. The next condition to discuss is Cheiralgia Paraesthetica, or Wartenberg's disease. This is very well known by radiologists. However, by and large, this is a clinical diagnosis and the imaging manifestations of this are very few. The patient typically complains of paresthesia on the posteroradial aspect of the thumb, and there is an area of tenderness with a localized Tinel sign around 9 centimeters proximal to the radial styloid. The important imaging clue here is that the condition arises from compression of the sensory branch of the radial nerve as it passes through the fascia between the brachioradialis and extensor carpi radialis longus. And this is where the nerve should be examined and compressed, seeking to elicit symptoms. So here we have the nerve lying beneath brachioradialis, and as the video loop runs, we'll see that it passes superficially, and at this point it's now lying between the tendon of brachioradialis and extensor carpi radialis longus, and as it passes through the superficial fascia, this is the point where there is the potential for entrapment. The hard bony radius lies just below, as you can see here, and if we just pronate and supinate as the nerve is passing through the septum, we can see how the nerve is mobile, trapped within the septum, and therefore prone to injury with this repetitive movement or with direct impact. The treatment is conservative. Most cases resolve with removal of the offending action, but occasionally hydroneurodilation and rarely surgery can help. The intersection syndrome, or crossover or squeaker syndrome, is also very well known in this area. And this condition occurs in the location where the first dorsal compartment crosses over the second. The symptoms are more proximal than de Quervain's disease, and very importantly, clinically, there is very often a crepitus to be felt and heard in this location. And it is this crepitus that gives rise to the nickname squeaker syndrome. The anatomy is very easily seen on this axial MRI, with the first dorsal compartment tendons associated with the terminal slips of the muscle crossing over the second extensor, and the abnormality occurs in between, felt to be present largely in the second extensor compartment due to the compression of the overlying tendon. With regards to imaging tips, in terms of MRI, again, it is the location of the edema as the tendons cross. For ultrasound, the presence of crepitus can be very useful to localize the abnormality, and then scanning in the area may demonstrate some of the synovial thickening with Doppler activity, as in this case. Treatment is again conservative, changing the repetitive action if possible, or if necessary, the sheath can also be injected. Another potential cause of posterior radial wrist pain to be aware of is what we will call volar plate impingement. And in this case, we're not talking about the volar plate of the finger, but we're talking about a surgically implanted device. The patient won't necessarily relate their dorsal pain to their previous volar surgery, but they will tell you that they've had a previous fracture with surgery. And this is an important clue to look for these areas where the tips of the screws just penetrate the dorsal cortex and impinge the undersurface of the tendon. In this case, the patient was symptomatic directly over the impingement point. But in some cases, even quite gross screw impingement does not necessarily produce any symptoms, as in this gross penetration of the second dorsal compartment in the second video. I won't say very much about the Carpal Boss. Most people are aware of this. It's a bony prominence at the base of the third metacarpal, close to the attachment site of the extensor carpi radialis brevis, and in some cases incorporating some of the attachment fibers. Sometimes it's a bony prominence, sometimes it's a coalition, sometimes an accessory ossicle. Many patients will have edema around the Carpal Boss, but there is no good correlation between the type of bony prominence and the presence of edema with symptoms. If necessary, the area can be injected, and very rarely surgery is required. The final condition I'm going to discuss is the distal intersection syndrome. Like its proximal counterpart, symptoms and signs arise as a result of one tendon, in this case the extensor pollicis longus, crossing others, in this case the second dorsal compartment. Here we can see the tendon in the black and white stripes, the EPL tendon, passing between the ECRL and ECRB, and this is the location where you look for the inflammatory signal changes, here easily identified on MRI. Sometimes included under the heading distal intersection is impingement of the extensor pollicis longus against Lister's tubercle itself. The unique anatomical orientation of the tendon, where it slingshots around Lister's tubercle, makes it prone to damage in this location. Whether it's ultrasound or MRI, look for the relationship between the tendon and the tubercle, and particularly look to see whether there's any irregularity or serrations at Lister's tubercle. These can occur in inflammatory arthropathies, particularly rheumatoid arthritis, and the constant rubbing of the tendon against the bony irregularities can result in tendinopathy and ultimately rupture, as in this case. So we've talked about a number of conditions that arise because of the unique anatomical arrangement of the tendons of the first three dorsal compartments and the overlying extensor retinaculum. What about some take-home points? Regarding de Quervain's disease, we've emphasized the importance of the thickening of the retinaculum, mentioning that in some patients this may be the only imaging finding, and how we can treat this by percutaneous division of the retinaculum if necessary. With Wartenberg syndrome, imaging findings are rare, but we should look for the nerve as it passes through the fascia between the brachioradialis and extensor carpi radialis longus. For intersection syndrome, it's important to examine the tendon crossover points for crepitus and look for any increase in fluid between the two tendons. On ultrasound, we may see Doppler activity to help us localize them. Be aware when patients have had volar plate fixation and subsequently complain of dorsal pain, particularly on tendon movement, and look for the sometimes subtle areas where the screws have passed through the dorsal radial cortex. Look for the important relationship of the extensor pollicis longus against an irregular Lister's tubercle, looking for early changes of tenosynovitis and tendinopathy, which may be the harbinger of potential rupture. Thank you very much.